Hello, 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 everybody. Good morning, good afternoon, good evening. Welcome, everyone. Ladies, gentlemen, guys, gals, and non-binary pals. I'm Monique Springer, Project Officer with UWIHARP, and I'm joined today with Kelia Anderson, our Project Assistant. A very special welcome to our students, staff members, colleagues with the National HIV/AIDS Commission, off-campus partners, repeat visitors, and to our new guests. UWIHARP is the HIV sexual health unit at UWI, and we seek to positively influence the sexual and reproductive health and wellness of the university population and the wider Caribbean society. Our primary focus is the development of sexual health literacy among the Caribbean community through programs such as our digital dialogues. These are sexual health conversations, and they will be held during the semester. They include the S-File Sexual Health Discussion Series on a wide range of topics, and the Shock Series, which will focus on sexual health issues among our vulnerable Caribbean populations during COVID-19. Look out for our flyers on our social media platforms, which include Facebook, Instagram, the UWI app, and through student UWI emails. There are a few participating guidelines. All mics are muted and videos are turned off, or they should be. Question and answer will take place after the presentation, and the mics will be unmuted. We ask you to post your questions or comments during the presentation in the chat pod located at the bottom of the screen. We aim to address as many as possible at the end of the presentation. Alternatively, you can message me directly if you prefer. For those questions we couldn't get to, please email them to uwiharp@cavehill.uwi.edu before the end of the day, and we will address them shortly afterwards. The sessions will be recorded, and the recordings will be posted afterwards on our social media platforms, which include our YouTube channel, UWIHARP Cave Hill. These will be done without the Q&A to protect participants' confidentiality. Please note that we cannot guarantee confidentiality in this public forum among participants, so be cautious about what personal information you disclose about yourself and others. It is safer to talk in general terms. Please complete the evaluation form that will be sent to you after the discussion. You can also suggest topics that you're interested in for us to facilitate. Now, there are a few rules, some of which we adapted from HIV 2020 online. UWIHARP's digital dialogues provide a safe space to address a range of sexual health topics using a sex-positive approach. We encourage participants to share their knowledge, experiences, and opinions in a respectful manner. You may disagree with views highlighted today. However, please be respectful of other outlooks, regardless of your religious or moral beliefs. Let us be mindful in the way we discuss sensitive topics. UWIHARP operates on a zero-tolerance policy for any kind of abusive, discriminatory, belligerent, or disparaging comments or actions that may cause distress to presenters or participants. Persons who engage in any undesirable behaviors will be immediately removed from the webinar unannounced. UWIHARP's guiding principle is to first do no harm. And today's topic, we have a very exciting topic. When sex isn't pleasurable, clinical perspectives on female sexual struggles. Last week we had our gentle warm-up into sexual health and looking at the male and female anatomy, reproductive anatomy, and today we are going to go straight into our cardio session with this very exciting topic. Today we will be focusing on cisgendered women. By that I mean a woman's sexual identity which is aligned with her gender identity. We acknowledge that this is not universal, as there are transgendered, intersexed, non-binary, and multi-spirited individuals that do not conform to the male-female dichotomy. We recognize, we see, and honor diverse sexual orientation and gender identities. Today, we will be looking at varying interrelated clinical categories of female sexual impairments and disorders. And Dr. Marshall, our featured speaker, will share a bit on some research that she's also conducted. Please note that some terms will have different readings and interpretations across disciplines and academic scholarships. And I'll introduce Dr. Ashana Marshall. She is a UE trained physician at both Mona and Cave Hill with a decade of clinical experience and a doctorate in family medicine. Her professional passions include patient-centeredness, holistic healthcare, and mental health advocacy. She currently works as a company physician, operates out of a private practice at Bridge Medical Clinic in St. George, Barbados, and facilitates case-based learning in the Faculty of Medical Sciences. Her personal mission is to learn more about herself, more about and from herself and others daily, and to be a good human who somehow contributes kindness, compassion, and empathy to those she has the privilege of encountering. I now invite Dr. Marshall.
Good afternoon, everyone. It is an honor to be here. I am Dr. Ashana Marshall, specialist family physician, and I am given the charge of talking to you about female sexual struggles and some clinical perspectives on that. It is quite a rather important and quite a rather large topic, and I'll try to do it justice in the short period of time so that we also have time for discussion and whatnot after. So even though this isn't the general heading that you'll be seeing on these slides, this is what I want to cover today. I want to do a brief overview of female sexual health with some definitions. I want to talk a bit about what research shows both internationally and locally, female sexual response cycles, some challenges that people tend to have, the kind of disorders that exist, and we can go into where people can seek help. Afterwards, I hope to have a discussion because it's supposed to be an interactive session. So let's get into it. Who is this talk for? So this talk is for women who want to learn more about sex and sexual health, and men who want to do the same, for people who have partners and people who don't. And it is tailored towards a non-medical audience, but clinicians and their questions are also very much welcome. And the good news is, if I fail in doing my job and you don't learn anything, there is 100% money back guarantee, and you will get exactly what you paid for to enter this session. Exciting. So let's go. The definitions that I'm using for the presentation: female, those will be assigned female at birth and identifying as female. Monique went a little into the other alternatives, but we're focusing on cisgendered females today. Sex and sexual activity. This is partnered or non-partnered, penetrative or non-penetrative. So sexual intercourse, oral sex, masturbation, frottage, any kind of sexual activity is being referred to today. And when we talk about sexual dysfunction and disorder, these are disturbances in the physiological and psychological changes that characterize the sexual response. And importantly, the disturbances have to be causing some kind of distress in the people that it affects, because there are people who don't have a high sex drive, who are not interested in having sex, and they are quite happy with it. We wouldn't characterize them as having dysfunction. So sex is an important part of human existence, and sex and sexuality are big parts of how we define ourselves. Sexual health and well-being cannot just be limited to having babies. Most of the sex that goes on isn't for purposes of procreation. And so sexual health has to integrate the recreational and the pleasurable aspects. If not, it is not being completely addressed. Sexual health and performance are multifactorial. There are lots of different things that contribute to how well it goes, and therefore sexual problems are as well. So sex is pretty complex. There are physical or anatomical factors that contribute, endocrine or hormonal factors, psychological factors, and social factors as well. So we'll get started with some anatomy of the female sexual organs because this is quite important. So the vulva. The vulva is external genitalia. Many people say, well, vagina and use that to reference everything on the outside. That's actually not accurate. External genitalia is called the vulva or the pudenda, a term that we tend not to use anymore. Pudenda actually means shame or source of shame in Latin, which would speak to the attitudes that people historically had towards sex. The vulva is made up of the mons pubis, labia minora, or the inner lips, majora, or the outer lips, the clitoris, the hymen, the vestibule, which is some erectile tissue, urethra, Skene's glands, vestibular glands, and those are important for lubrication, and vestibular bulbs are also erectile tissue. And this is a very up close and personal diagram just showing the different aspects that we would have spoken about in the previous slide. So the clitoris is getting some extra attention, which, as we will discuss, is quite important in sexual pleasure. It is an erectile structure. It is analogous to the male penis. So some say that having pleasurable sex without any kind of focus or attention to the clitoris is more difficult, similar to how it would be difficult to have pleasurable sex without focusing on the male penis. There are evolving views of the extent and the shape and structure of the clitoris, and it was once thought that it was a sign of infantile sexuality, meaning as you got more mature in your sexuality, then you would be able to achieve sexual pleasure without using it at all. But we know that that is not the case. Once it was thought to just be the size of a pea, but now we know that it extends, most of it below the surface, to 9 to 11 centimeters. It has thousands of sensory nerve endings, and there have been studies demonstrating linkages between the orgasm frequency and the distance that exists between the clitoris and the urethral meatus, which would be basically where urine comes out. So, anatomy of the female sexual organs. We have internally vagina, vaginal canal, which runs from the cervix to the introitus, which would be the entrance to the vagina, the uterus or the womb, the cervix, the fallopian tubes, where fertilization and tends to take place, and the ovaries, which store eggs, ova. I know I will be asked about the Gspot. The Gspot or the Grafenberg spot, it describes an erogenous zone, a pleasure center, located in the anterior vaginal wall. Now, it is something that is very popularly spoken about, but something that has not quite been isolated anatomically speaking. There is one scientific study where it was isolated, but that is a single cadaver study, so not a whole lot of objective descriptive evidence there. So based on that, it's also suspected that the Gspot might just be a center of erectile tissue that happens to be there. The research is still ongoing. So the female sexual response cycle. Masters and Johnson proposed this linear model, which basically takes us from excitement to plateau, orgasm, sometimes, and resolution. Now, in males, it tends to go straight from excitement, plateau, orgasm, resolution, and the gap that we're seeing here is called the refractory period, which is basically the time between when you can have one climax and another, the time it takes you to get excited and go through the whole process all over again. Whereas in women, you know, women can go from excited to the plateau stage and have resolution without any peak. Some women can skip stages, and because of this, other models were proposed. So the excitement phase, this is the initial physiological sexual arousal response, and it is characterized by increases in heart rate, breathing rate, blood pressure, muscle tone, and general blood flow towards the genitals and the skin. And the uterine position comes up a bit and vaginal lubrication begins. The plateau phase tends to be characterized by intensification and increases in those changes, with orgasm being a peak or sexual climax of excitement, with involuntary rhythmic contractions and euphoria and tension relief as some of the things that can occur. Which brings us back to resolution, returning to baseline, feelings of calm, muscles relaxing, blood pressure, heart rate, and respiratory rate reapproaching normal, and blood flow to the genital region decreasing. The refractory period, like I said, is typically longer in men. Okay, so with it in mind that women don't necessarily go from one stage to the other, instead of a just linear model, there was more of a cyclical model proposed, and this is one popular one that also takes into consideration the different things that can be a part of sex: emotional intimacy, feelings of increased well-being, biological factors, and psychological factors. So a more holistic model, which is really important. And this slide is just a bit of light humor, and also so that I can take a pause because I've been talking rapidly for a few minutes now. Okay, so psychological and social factors that might influence how people experience sex: self-concept or the body positivity, how you feel about yourself, how you think other people should feel about you, how you think you are viewed, because a part of sex is being able to be present in the experience. So if you tend to be worried about how people see you, what people might be thinking, if you're really worthy of the experience, if your partner's really attracted to you, those kinds of distractions tend to result in less than satisfactory sex. Your religious upbringing is very important. So for example, if you're told that sex should only occur under certain circumstances, marriage, trying to have a baby, you might feel guilty and ashamed to have it outside of that. And that would result in decreased sexual satisfaction, or sex that comes with a lot of intrapsychic conflict, feeling one thing, feeling another thing, and just generally being confused. Relationship satisfaction, for those in relationships, and for those not in relationships, your relationship with yourself is very important in terms of sexual satisfaction and performance. Cultural norms are important, your upbringing for reasons previously discussed, and education and expectations. Now, these are big ones, which brings me to the influence of media on our education and expectations. So, pornography. Pornography has to be recognized as adult entertainment and not education. And an issue that tends to come up is that for some people, especially people who are not brought up in sex-positive environments where there might be training against sex or discouragement, but not a whole lot of discussion about what sex actually should be like or could be like. People go to where they can find sex, and that is usually pornography. Easily accessible, but not education. It doesn't show the stuff that tends to happen in a real life sexual encounter. So issues of consent, things not going well, bodies making weird noises, people having to stop and restart, people needing to use contraception, people needing to protect themselves against STDs. All of these kinds of things are not discussed, and so it gives the impression that sex goes from point A to the end point quite smoothly, and that is not accurate. It does have its place as entertainment and also to gauge interests and inclinations and help with low libido in some persons, but expectations must be managed. And we're not just going to talk about pornography, we can also talk about movies and magazines, things targeted towards young women. Usually they're exposed to them from quite a young age, because many of them start marketing towards teenage women and they perpetuate these certain stereotypes. So I don't make nearly enough to cover myself in a lawsuit, so I will not name any of these magazines. However, I just took some clips from real magazines. I'm sure those of us who have been exposed to them can look at these headlines and kind of name which magazine they're from. This sex tip number 46, I had to include. I know we talk about staying sexy and keeping things spicy, but I really don't think that this is what was meant by that. Black pepper, vulnerable situation, really wouldn't end well in most cases. So let's talk about the research that was done. So in the United States, it has been found that at least 40% of women suffer from some kind of condition which involves sexual pain, arousal, or orgasm difficulties. And the biggest problem through all age groups is actually low desire. And other parts of the world have reflected such. Lowest ranges are around 20%, higher ranges above 40%. And in the Caribbean, there wasn't that much research done in the general populace, but just an example of a prevalence figure was 40% in a Puerto Rican study. There is an international consensus that regardless of where we study and regardless of the method used, there is a prevalence of about 40 to 50% in terms of sexual difficulties, regardless of age. And in a study done, there was that high of a prevalence. This study was actually done in a clinic, but when they went into the patient's notes to see what was actually documented or asked by the physician, only 2% had any kind of complaint regarding sexual function documented in notes. So this is something that we have to pay attention to as clinicians, and also something that we have to pay attention to as patients. We are best suited to advocate for ourselves. The challenge is that several studies have also confirmed that while more than half of patients affected would like to discuss these things with their doctors, more than 70% would like the conversation to be provider initiated. So that's a note to the clinicians among us as well. So some local research was done by this lady, Ashana Marshall. Yes, we did some research in Barbados. I think that was 2016 to 2017. There wasn't any data on it, and we sought to collect some. We had a representative sample, 367 women, and we attended 4 of the 9 polyclinics. We selected those to get a good sample of different populations in Barbados, urban and rural, one end of the country to the other end of the country. The age range was between 18 and 65, and the questionnaires were self-administered. There were 2. There was an internationally recognized standard questionnaire that just screened for the presence or absence of sexual symptoms. And then there was one that I created to find out the kind of factors that might be associated. And I always take the opportunity to thank and give props to my interviewers who were just awesome, generally. And the clients were very comfortable with them and their level of training. So my research showed quite a bit. Takeaway points were just over half of the people interviewed showed that there was some likelihood of sexual dysfunction. 1 in every 5 women had trouble with penetration, which and pain. And pain is important because pain can actually be addressed by the physician, but many of them hadn't sought to do so. 11% of women interviewed had never been able to comfortably have sex in ways that involved penetration at all. And less than half of the women interviewed, less than half, felt like they could go to their doctor with their problems, which was very interesting and disheartening, but it's something that we have to be mindful of. It's also possible that this could have been because we were in a polyclinic setting. And, you know, the time you spend in with the doctor tends to be short compared with the time that you're out because of limitations in time and resources. So we do recognize that that could have been a factor. We reflected that increasing age and increasing likelihood of female sexual dysfunction was, yes, there was agreement there, and the statistically significant relationship covered all the domains: penetration, sexual satisfaction, differences in sexual interest. But when you compared it among age groups, it was not that these things, with regard to sexual interest, low sexual interest was happening among the older women and not the younger women. Again, similar to what the international study showed, it was a universal thing. Diabetes, which is very common here, had a significant relationship with sexual problems. Lower relationship satisfaction, well, yes, if you were dissatisfied in your relationship, you tended to be dissatisfied with your sex life. And lower levels of education also resulted in, or were associated with, rather, higher rates of sexual dissatisfaction. This chart just shows that consistently across age groups, there was a decrease in interest in sex. Things that I didn't find to be statistically impacted were sexual orientation. That didn't statistically impact FSD. Sexual orientation, that brought up some interesting findings. People were quite reluctant to disclose what sexual orientation they were, and that is understandable. I take some responsibility for that, because a more appropriate question, instead of are you homosexual, heterosexual, bisexual, would have been, do you have your last few encounters, or have your encounters been with men, women, or both? Live and learn. Number of sexual partners were not seen to be linked to sexual satisfaction. Neither was employment status, number of children, and religion, meaning whether you were Muslim, Christian, Hindu. So FSD. FSD is disruption in any one of these stages, and some ways of characterizing them: female sexual interest arousal disorders, female orgasmic disorders, and genital pelvic pain penetration disorders. These are according to the DSM-5. So DSM-5 is just one way of categorizing things, Diagnostic Statistical Manual, version 5. And it says that these things have to be happening for 6 months unless there is a direct cause noticeable. And also this just says that the last update just merged some terms that might have been more commonly used, like vaginismus and dyspareunia. And we also have to take note of other things that might be contributing factors. This is a table that I put together, just showing different classifications according to the international body. But what I wanted to point out is that there is sexual dysfunction that can occur after smooth sailing through the sexual experience, where some people after orgasm, they tend to get headaches, fainting, feeling generally unwell. So we have to bear that in mind as well, and also realize it's something to report and have investigated. This is just the criteria for female sexual interest arousal disorder. Very busy slide, sorry about that. But basically, the emphasis is that you have a lack of interest, initiation, sexual thoughts or fantasies in 75 to 100% of sexual encounters. And I will stress again, it causes problems. There are some people who are asexual by nature, and that is just their norm. They're happy, and they would not be categorized as having female sexual interest and arousal disorder. Female orgasmic disorder is marked delay in or reduced frequency of or absence of orgasm or decreased intensity of orgasmic sensation. It's always important to find out what the person's expectations of orgasm are, because some studies have shown that when brains have been scanned, some women were having orgasms and didn't realize that they were, just because of what they expected. And then genital pelvic pain penetration disorder. We will go into the different contributing factors there. Oh, one thing I wanted to mention here, not just having pain and not just having difficulty with penetration, but also to an extent where it makes you apprehensive about the next sexual encounter. Now, in my day-to-day practice, and just generally, I like to think about icebergs. What you see on the surface is so small compared to the extensive nature of what is under the surface. And it reminds you not to make assumptions and also to dig a little deeper to get to the bottom of what might be going on. Approaching FSD is no different. We need a thorough patient-centered history. As a family physician, shameless plug for patient-centeredness. So it's holistic, person's ideas about what might be happening and why, how it affects them, not just the illness, but the illness experience is very important to address. You include the past medical history and drug history, including herbal medications and supplements, recreational drugs, take a good social history, find out the living situation at home, gynecological history, and relationship and mental health history. Partner involvement can come into play, but there always has to be an individual assessment to find out what is going on. So people should generally be prepared to come and just initiate a discussion and realize that some personal questions, if you feel comfortable, can be asked. There is a general examination because not all causes of sexual dysfunction start within the genitalia, but there is a genital examination as well once the person attending gives permission. Nothing can be done without consent. Investigations might include screening for sexually transmitted infections. This is very important because some people tend to think that there would be these big extravagant signs if they were ill, and that is not always the case. Education is very important. We'll go into that, and recommendations and referrals. Your physician has the responsibility to know their limits and know who can help. So even if you feel like my doctor is not going to be able to help, or you get that inclination, we know that there are people out there who can, and we can direct you to them. Risk factors for sexual problems in women are myriad because sex, like we said, is complex. Any hormonal conditions, menopause, can lead to degeneration of tissue, dryness, pain, change in your birth control, injections, pills, IUDs, whether or not you just had a baby, whether you have polycystic ovarian syndrome, which, you know, there's a hormonal impact of that, but then there's also the fact that that tends to come with excess hair, excess weight, excess acne, and so some people feel quite self-conscious about it. And it's important for me to say, I am not saying that if you're on birth control to stop doing that. It's just about finding the one that works for you and reporting it so that if we find a link, we can help. Psychological factors, because mental health cannot be separated from physical health. It cannot. Depression, anxiety, fatigue, poor partner support. Is the person expected to do all the chores at home and then expected to perform sexually at night? Is there a lack of privacy? Are you living in a home where you can't relax and feel comfortable? Do you have a history of abuse? Is there sexual dysfunction on the part of your partner that you might be assuming responsibility for or feeling disheartened because of? And the presence of neurological conditions, non-communicable diseases, diabetes and hypertension, back to that again, can also contribute as well. Diabetes mainly because, well, diabetes we've established. Hypertension, not directly because of the hypertension usually, but because antihypertensive medicines tend to decrease blood flow. Again, not saying to stop taking your antihypertension meds, just saying to discuss it with your doctor so that other alternatives can be approached if necessary. So other things that can cause sexual problems in women: medications, hormonal medications, contraceptives, antidepressants of a particular class, like I mentioned, antihypertensives, substance use, not just because of the substances being used, but also because the reasons that you might be using the substances. Those things can contribute to sexual dysfunction. And then social factors such as lower educational levels, lower income, poor health status, poor housing, mental health disorders, and lack of sexual education. Now I wanted to talk specifically about female sexual pain. Pain during sex, unless that is what you set out to achieve, is not normal. And it is something that your general practitioner, your family physician can actually help you to address, because there's so many things that can cause it that can be addressed. And the things that you should take note of when you're coming in to see the doctor and just in general are where or when does the pain occur? Does it happen with any kind of genital contact? Penetration, early or late, with thrusting? And it's important to know because causes can be infectious, anatomic, hormonal, traumatic, due to structural things like fibroids. And it's also important to identify if it started at a particular time or with a particular partner, if it started early in the sexual encounter or late, and if the pain only occurs during the sex and only occurs in the genitals. So there are lots and lots of reasons why people can have pain, ranging from issues with just the skin to nerve issues to simple and common things like yeast infections, sexually transmitted infections, and vaginismus, or hypertonicity of the pelvic muscles, which is involuntary contraction, which tends to lead to difficulty with any kind of penetration. Perineal problems, so the pelvic floor muscles and any damage that might have been there and repaired. Bladder infections, problems with the internal female organs. Fibroids are very common. It's estimated 1 in 4 women, Black women, has fibroids, endometriosis. And after having surgery, scar tissue is less flexible and it can cause some problems during sexual intercourse. So that's something to bear in mind. And then extra pelvic stuff, fibromyalgia, chronic pain disorders, arthritis, and again, anxiety and depression. So management, it's in red because it's important, is to find out what might be causing it and address the underlying issues. That is important. And it's equally important to know that most people will not need any kind of medication, just different interventions. Education, again, about normal female anatomy and sexual physiology so we can manage our expectations and work towards different outcomes, lifestyle changes to improve body image, exercise to increase blood flow and self-esteem, reducing work hours if stress is a problem, reducing household chores, etc. Lubrication is important. Other sexual aids are important as well. Personal therapy, couples therapy, sex therapy, any kind of therapy where you take the time to explore yourself and your issues and what might be underlying tends to be helpful. Pelvic physiotherapy is helpful. And I should say all of these types of therapists, we have excellent ones here. And I'm sure in the course of this series, you would have been exposed to some. And if you need some names, I know that they can be provided to you once you email. Other things that can be tried are directed masturbation, learning about your own body so that you can then direct somebody else, and also partaking in sexual activity without an aim to just have an orgasm. Systematic desensitization, progressive vaginal dilatation for those with increased tone and difficulty with penetration. Sensate therapy, focusing on the journey as opposed to the destination, and mindfulness, being present in the moment instead of just running through, okay, after this, I need to do this, or I need to do that, or, you know. So I know this is a scientific presentation. I don't know if this is true. I didn't look it up, but the point is we have to take some responsibility for our own sexual pleasure, and there is a tendency among women to not say much and to pretend like they're having a good time when they're not, but that ultimately will not help. So management of FSD, there are drugs. Sometimes it's not starting a drug, sometimes it's stopping a drug that's causing a problem. Sometimes it's hormonal therapy, sometimes it's pain management or anesthetic that can be applied before a sexual encounter, treating underlying infections. So antibiotics might be necessary. Bupropion is an antidepressant, which is not of the class that causes that kind of issue. Sildenafil is Viagra. Doesn't have consistent evidence for improving outcomes in women, but it can be tried. It just varies based on the underlying cause. So who is there to help? General practitioner, friendly neighborhood family physician, gynecologist, psychologist, sex therapist, pelvic physiotherapist, your psychiatrist, your pharmacist, your partner, but the most important person is you. Recognizing that you have an issue, taking the bold step of advocating for yourself and coming to try to get some help and just seeing if there's a problem. So some questions that were asked prior to the presentation, really interesting questions. I'm just going to run through them so that we can have a discussion. It is possible that a woman can be allergic to a man's ejaculate and then have itching, swelling, burning, and pain. Yes, that is possible. Needing lubricant is not a sign of dysfunction, especially when a foreign object such as a condom is involved. More friction leads to discomfort, tearing. Any tearing increases the likelihood of having an infection. With sex, wetter is better. And water-based lubricant should be used with condoms because otherwise they can degrade. Birth control pills do not permanently affect fertility. Not all sexually transmitted infections present with symptoms. Vibrator use does not permanently decrease or damage your genitals. Temporarily, there can be some numbness, just like how if somebody, male or female, practices having sex or masturbating a particular way to achieve a certain result, they might find it difficult after a while to do that in other ways, but with effort and redirection, that can change. Vaginal steaming, there is no sound scientific evidence to support that practice, and it's a very commonly asked question. And again, unless pain is what you are into, sexual pain is not normal and could be addressed by your doctor. I always include this quote because this is one that reminds me why I do what I do. It was from our research paper. Sometimes just talking about the problem and realizing that you are not alone can bring great relief. The key points: if you suffer from any sexual disturbances, you are not alone. It's actually quite common. There are people who can help you. You can talk to your doctor. If you're dissatisfied there, talk to another doctor. There are people who can help. Advocate for yourself in sexual scenarios, in the bedroom, out of the bedroom, in the doctor's office. If you feel like you're not being listened to or your concerns aren't being acknowledged or validated, then that's something to speak up about as well. Lots of references, and I thank you so much for your attention. I will take your questions and we can have a discussion at this time. Thank you.
Great. Thank you so much, Dr. Marshall. That was a really, really good presentation. And I've had a couple of people message me. Thankfully, I was able to answer those simple questions.